a common surgery with complex cardiac considerations. An ischemic heart disease patient posted for mastectomy. We have Dr. Shalini Mariam Aip, Associate Professor of Anesthesiology and Critical Care, MOSC Medical College, Kolanjeri, and Dr. Ashu Sara Matai, Head of Department, Believers Church Medical College, Tiruvalla. We request you to please come on to the dais.
We have Dr. Arati Banachandran and Dr. Ajanya Tarankan from MOSC Medical College, Kolanjeri, to present this case. From risk stratification to intraoperative cardiac stability, this session promises depth and insight.
Good morning. Our case is on ischemic heart disease patient for mastectomy. Radhika, 55-year-old female, homemaker, hailing from Thrissur, presented with lump in the right breast for 1 month. History of present illness. Patient was apparently normal 1 month back. She noticed a lump in the upper outer quadrant of right breast. Swelling gradually increased in size. Not associated with pain, fever, color change, nipple discharge, nipple inversion, skin ulceration. No history of trauma to chest pain, weight loss. Past history. She is a known case of coronary artery disease, underwent coronary angioplasty 2 years ago. Percutaneous transluminal coronary angioplasty to left anterior descending artery was done with drug-eluting stent. History of hypertension since 6 years and was on irregular medication. No history of any surgical intervention. No history of COVID infection or blood transfusion. No history of chest pain, breathlessness on exertion or lying down, pedal edema or paroxysmal nocturnal dyspnea. No history of cough, upper respiratory infection, fever. No history of syncope, giddiness, sweating, headache. No history of diabetes mellitus, thyroid disorder, seizure disorder, cerebrovascular accident, tuberculosis. Patient was able to do her daily activity on her own like gardening and cleaning, that is meds more than 4. Treatment history. No non-drug allergy. She is on tab nitroglycerin 2.5 milligram once daily, tab aspirin 150 milligram once daily, tab atorvastatin 40 milligram night, tab clopidogrel 150 milligram once daily, and tab metoprolol 40 milligram once daily. Family history. Her mother had a history of hypertension. No history of coronary artery disease in the family. Personal history. She is a vegetarian with normal appetite, adequate sleep, and her bowel and bladder habits normal. Menstrual history. She attained menopause at 48 years of age. No history of oral contraceptive pills or hormonal replacement therapy. To summarize, Mrs. Radhika, 55-year-old, postmenopausal female with non-case of hypertension, coronary artery disease on drug-eluting stent taking dual antiplatelet therapy, presented with painless lump in the upper outer quadrant of right breast for 1 month. Her functional capacity is more than 4 meds and she is currently on nitroglycerin, aspirin, clopidogrel, atorvastatin and metoprolol.
Coming to the general examination, patient is conscious, oriented, moderately built and nourished. She has a weight of 68 kg, height of 158 centimeter, and BMI of 27.2 kilogram per meter square. She has no pallor, no icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Her skin, hair and thyroid appears normal. Vitals. She has a pulse rate of 66 beats per minute, which is regular in rhythm, normal in volume and character, no radioradial or radiofemoral delay. All the peripheral pulses are felt equal and bilateral. Blood pressure. She has a blood pressure of 130 by 76 millimeters of mercury, measured in left upper limb in supine position. She has no postural hypotension. Respiratory rate is 16 cycles per minute, which is thoraco-abdominal in nature. The patient is febrile. JVP is not elevated. She has a normal skull, spine and gait. Upper airway examination is normal. And coming to the cardiovascular system examination, inspection, shape of the precordium is normal, apical impulse is not visible, no suprasternal or epigastric pulsation, no dilated veins, scars or sinus. In palpation, apex beat is felt at left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. She has no parasternal heave, no thrills, no palpable pulsations, no palpable P2. In percussion, right heart border corresponds to right sternal border and left heart border corresponds to apex. Auscultation, S1 and S2 is heard normal in mitral, tricuspid, pulmonary and aortic areas. She has no murmurs, no added sounds or carotid bruit. Other systems are normal, within normal limits. And in local examination, a lump is present on the right upper quadrant of breast, which is non-tender and measuring approximately 5 into 5 centimeter, which is hard in consistency, ill-defined margins and irregular surface, and has a restricted mobility. On examination of right axilla reveals no palpable lymphadenopathy, and overlying skin is also normal. Coming to the diagnosis, a 55-year-old post-menopausal female with history of hypertension, ischemic heart disease on dual antiplatelet therapy with drug-eluting stent to left anterior descending artery with a suspicious lesion in the right breast.
Okay, can you classify hypertension?
According to 2024 ACC AHA guidelines, hypertension is classified into blood pressure, which is normal, where systolic blood pressure is less than 120 millimeters mercury, and diastolic blood pressure less than 80 millimeters mercury. Elevated BP is SBP between 120 to 129 millimeters mercury, and DBP less than 80. Hypertension, stage 1 hypertension is SBP between 130 to 139 and DBP 80 to 89. Stage 2 hypertension, where SBP is more than or equal to 140 and DBP is more than or equal to 90.
Can you just mention the name of the drugs that are used in its treatment?
Hypertensive drugs are classified into renin-angiotensin-aldosterone system inhibitors like ACE inhibitors or ARBs. Diuretics like loop diuretic, thiazide diuretic, potassium sparing diuretics, beta blockers, calcium channel blockers, vasodilators like hydralazine, and centrally acting sympatholytics like alpha-methyl dopa, alpha-methyl dopa.
Good. What are the risk factors for development of ischemic heart disease?
Risk factors of ischemic heart disease include modifiable and non-modifiable risk factors. Non-modifiable risk factors include male gender, increased age and positive family history. And modifiable risk factors include history of smoking, hypertension, dyslipidemia, diabetes mellitus, obesity and sedentary lifestyle.
What are the types of myocardial infarction?
The types of myocardial infarction are type 1, where myocardial infarction is due to acute rupture of atheromatous plaque, and type 2, where acute myocardial infarction is due to oxygen supply demand mismatch, and type 3, it is a postmortem MI, where patients had signs and symptoms of MI, but they passed away before evaluating the biomarkers, and type 4 is classified into A, B and C, where A is due to post-PCI within 48 hours of the index procedure, and B is due to stent thrombosis, and C is due to restenosis. And type 5 MI is post CABG MI, which occurs within 48 hours of CABG.
So in a patient with an acute myocardial infarction, can you correlate the ECG changes seen in specific leads with the walls of the heart affected and the coronary arteries involved?
So septal wall is supplied by the septal branches of left anterior descending artery, and the changes are seen as ST elevation V1 and V2. And anterior wall of left ventricle is supplied by the left anterior descending artery, and the changes are seen as ST elevation V3 and V4. And the lateral wall of left ventricle is supplied mainly by the left circumflex coronary artery and left anterior descending artery, and the changes are seen in 1 AVL, V5 and V6. Inferior wall of left ventricle is supplied by right coronary artery, and the changes are seen as ST elevation 2, 3 AVF. And posterior wall of left ventricle is supplied by posterior descending artery, which is a branch of right coronary artery in most of the cases, and is seen as ST elevation in V7 to V9 and ST depression in V1 and V1 to V3.
Okay, well done. Now, this patient has come to you in the PAC OPD and you have just seen the patient. How do you assess this patient further? What are your next steps?
Assessment of this patient further can be done by cardiac biomarkers, stress ECG, stress echo test, or by cardiac MRI or invasive procedures like coronary angiography.
You mentioned cardiac biomarkers. So can you tell me a little bit more about the various biomarkers that you know?
Cardiac biomarkers are the protein molecules that is released into bloodstream by the ischemic myocardium. So the first biomarker that is raised after an acute MI is myoglobin, although troponin is very sensitive and specific for MI. And LDH, although not specific for MI, LDH1 more than LDH2 indicates an MI. And CKMB, that is creatinine kinase myocardial band, remains only for a shorter duration, but its persistence indicates myocardial infarction extension. And newer markers are ischemia modified albumin, pro-brain natriuretic peptide, glycogen phosphorylase isoenzyme.
Right. So now in our ACCHA guidelines 2024, we have the pro-BNP and the troponins that have been clearly there in that. No? Do you know of any other conditions that could cause a rise in the pro-BNP other than cardiac?
Pro-BNP is mainly raised in increased left ventricular volume or pressure. So in cases of heart failure or left ventricular hypertrophy, pro-BNP can be increased.
Okay. Also in chronic renal failure. So chronic kidney disease, pulmonary hypertension, pulmonary embolism. So those could be the things that might also cause an elevation pro-BNP, and you might think it's a cardiac cause, right? Right. Now, what is the indication of coronary angiography? Would you do that in this patient, for example?
No, since the patient is not having any acute symptoms, no need. If coronary angiography is more indicated in patients who have symptoms despite medical therapy, severe symptoms despite medical therapy, or those who have acute coronary syndromes as an unstable angina, NSTEMI, and those who are undergoing coronary revascularization procedure, and to estimate or to evaluate valvular heart diseases, and also if there is any unexplained heart failure, or those who are on high risk category or non-invasive testing.
Right, where you think that your management might change if you do the coronary angiogram, then you might proceed for that. No, otherwise there is no indication. Okay. Now, how would you classify the surgery based on the cardiac risk?
Surgery based on the cardiac risk can be classified into high risk, intermediate risk, and low risk surgery, where high risk indicates more than 5% of risk of MACE, and intermediate risk is 1 to 5% risk of MACE, and low risk is less than 1% MACE, where high risk surgeries include aortic surgeries, major vascular surgeries, intermediate surgery like intra-abdominal or head and neck surgeries, and low risk surgeries, breast surgery or cataract surgeries.
So this patient will come into which category?
This patient comes under low risk of MACE, less than 1%.
What is this MACE for the sake of our audience?
MACE is major adverse cardiac events. That is major adverse cardiac events like MI or sudden cardiac death or cardiac arrest that can arise in a patient. And the assessment of MACE is done by RCRI risk index or NSQIP calculator or by functional capacity. And the assessment of MACE also helps in evaluating perioperative cardiac risk and guides anesthesia management.
Can you elaborate on this RCRI and NSQIP risk index?
Revised cardiac risk index, the criteria included are history of any ischemic heart disease, history of any cerebrovascular accident, history of congestive cardiac failure, or if it is a high risk type of surgery, or serum creatinine more than 2, or diabetes mellitus requiring insulin. Each criteria is given 1 point, and based on these points it is classified into class 1 to 4. Class 1, 0 points, the risk of major cardiac events is 0.4%. Class 2 is 1 point, the risk is 0.9%. Class 3 is 2 points and the risk is 6.6%. And class 4 is 3 or more points and the risk of major cardiac events is 11%. And American College of Surgeons National Surgical Quality Improvement Plan is used to estimate 30-day postoperative complications, perioperative risk of MI, cardiac arrest, etc. It is superior because it considers both patient and surgical factors.
Right. So, how would you choose between the two? Or would you do both in all patients?
Revised cardiac risk index
is more
comparatively easy
yeah,
to
it can be done at the bedside. This you would need to log in, get into the ACS site. You don't have the weightage given to you. So you need to enter the data and the final weightage and score will only come if you do it online. So if you have time, this is a better score to do, right? Now, how would you assess functional capacity? What do you understand by functional capacity?
Functional capacity of the patient can be measured by structural as well as non-structural method. And non-structural method involves calculation of metabolic equivalent of tasks by patient's clinical history or NYHA classification. And a non-structural and structural method involves Duke's activity status index and cardiopulmonary testing. And coming to the metabolic equivalent of tasks, where 1 METs is equal to the oxygen consumed by the patient at rest, that is around 3.5 ml per kg per minute. And if the patient is having more than 10 METs, he is of excellent functional capacity. If more than 4, it is good to moderate functional capacity, and less than 4 is poor functional capacity. Duke's Activity Status Index is a self-reported questionnaire to evaluate the patient's physical ability, and from this it is scored from 0 to 58.2, where the METS is calculated from DASI score by 0.43 into DASI score plus a 9.6 by 3.5, where the value more than 35 gives good functional capacity and less than 25 gives poor functional capacity.
Right, and one cutoff for DASI would be 34, right? You would know that, yeah. So now can you walk us through the perioperative assessment of this patient as per the guidelines that is now available to us?
If the patient is for an emergency surgery, we can proceed with the surgery and optimize as much as possible. If patient is for if patient is having, it's not an emergency, then we have to check for active cardiac symptoms like decompensated heart failure, significant arrhythmia, and severe valvular heart disease. Then if it is present, patient should be evaluated further and delay the surgery as much as possible. If not, then patient's physical If not, the functional capacity of the patient can be measured by RCRI or NSQIP. If patient is having a low risk of MACE, patient can proceed with surgery. If high risk of MACE, patient should be again patient's metabolic equivalent of task should be calculated. If it is less than 4 METs, more than 4 METs, patient can proceed with the surgery. If less than 4, we have to again calculate the biomarkers, where the NT-proBNP and cardiac troponins. If the troponins are normal, then we can proceed with the surgery. If not, if it is elevated, then we have to go for stress echo or stress ECG test. And if it is of normal value, we can proceed with the surgery. If the patient shows high risk, then we have to go for any invasive procedures, or surgery should be deferred for a later date.
So now we have a patient who has got a drug-eluting stent placed around 2 years ago. She's on dual antiplatelet therapy. She also has a lump in her right breast, which you said looks suspicious, with no nodal involvement. Would you like to proceed with some surgery?
Since the patient is having a lump, painless lump, which is with restricted mobility and hard in consistency with irregular margin, it is suspicious of right breast malignancy, and would like to do a right symbol mastectomy, and this is time-sensitive surgery.
What do you mean by time-sensitive surgery?
Time-sensitive surgery is that surgery can be delayed for up to 3 months, so that without negatively impacting the outcomes.
Is there any classification with urgency of surgery?
Yes, emergency surgery is surgery that should be taken place within 2 hours, and urgent surgery is surgeries that should take place within 2 to 24 hours, and time-sensitive surgeries should take place within 3 months. And elective surgeries can be the surgeries that can be done with adequate pre-op evaluation and management of the patient.
So this is a change from our earlier guidelines. So it is important for all our PGs to know this change. Right.
Can you tell us more about the various coronary stents?
Coronary stents are of bare metal stent and drug-eluting stent. Bare metal stent are metallic mesh stents without any drug coating, and a risk of restenosis is high in this type of stents. And drug-eluting stents are metallic stents with drug coating, and these are first-generation stents. The drug used is sirolimus and paclitaxel, and the risk of late stent thrombosis is high in these cases. And second-generation stent, the drugs used are everolimus and sotarolimuz, and on a platinum and cobalt chromium base, and it is most commonly used nowadays, and the risk of stent thrombosis is very much less in this kind of patients. And the third generation is bioabsorbable, biodegradable polymers, where polymers completely get absorbed, and it's of less complications.
So what is the time that's recommended between placement of a stent and surgery?
12 months after drug-eluting stent. In case of bare metal stent, it is 30 days, and after CABG, it is 6 weeks, and after coronary angioplasty without any stent, it is 2 to 4 weeks.
So now let's discuss the perioperative management of dual antiplatelets in patients who have got a coronary stent in situ.
As per the 2024 ACC-AHA recommendations, the timing of surgery and perioperative antiplatelet therapy should be based on risk of bleeding, thrombosis, and consequences of delayed surgery. And it is recommended to continue aspirin to reduce the risk of cardiac events. And also, if the duration of bare metal stent is less than 30 days or drug-eluting stent less than 3 months, the dual antiplatelet therapy should be continued unless the risk of bleeding outweighs the benefit of stent thrombosis, prevention of stent thrombosis. In selected patients with drug-eluting stent less than 6 months and bare metal stents less than 30 days, we can bridge it with antiplatelet intravenous therapy.
So, in your patient, what is your recommendation?
Since it is a low-risk surgery and the drug-eluting stent is placed 2 years back, we can continue dual antiplatelet. Or even if in view of bleeding, we can even stop clopidogrel for 5 to 7 days as per the latest ASRA guidelines.
So, you're saying because your patient has a stent placed 1 year ago and low risk for bleeding in the surgery, the recommendation is to continue dual antiplatelets, but maybe surgeons do not want to do so. So it is safe to
of
even
increased
stop
bleeding.
Cloplet and just put the patient on aspirin. Okay, good. Now, can you identify the various pharmacological agents that are used in bridging therapy with antiplatelets?
We can use short-acting glycoprotein 2B3A inhibitors like tirofiban, eptifibatide that can be continued till 4 to 6 hours prior to surgery. And also we can use intravenous cangrelol which can be continued till 3 hours prior to surgery as per the latest ASRA guidelines.
Can you quickly take us through the cardiac medications this patient is on, the rationale behind why you started it and whether it should be stopped before surgery?
Patient is on nitrates. Nitrates can dilate coronary vessels and decrease the preload. These can also decrease the peripheral vascular resistance and decrease the afterload. And these can reduce the duration, severity, and frequency of angina and increase the exercise tolerance for further anginal attacks. And these have antithrombotic properties, so nitrates should be continued on the day of surgery. And the patient is also on metoprolol, which is a beta blockers. Beta blockers decrease the myocardial oxygen demand, and also these increase the duration of diastole and improve coronary circulation. And these have anti-ischemic, anti-hypertensive, anti-arrhythmogenic properties and membrane stabilization properties. So beta blockers should be continued on the day of surgery. And the patient is also on statin, which has lipid lowering properties, and these have plaque stabilization, anti-inflammatory, and decreasing the cardiovascular risk of the patient. So statins should also be continued on the day of surgery.
Suppose my colleague mistakenly stops the beta blocker on the day prior to surgery. What are the problems that could occur?
Since the patient is on beta blockers, there is upregulation of beta receptors. So when we abruptly stop the beta blockers, there can be chance of rebound hypertension, which will increase the myocardial oxygen demand and precipitate myocardial ischemia.
All right. And would you start beta blockers, say, 2 days before the surgery because it's so beneficial?
No, because as per the POISE-1 trial, starting the beta blockers just before surgery can increase the risk of stroke, hypotension, and bradycardia. So it is advised to start at least.
So predominantly because of hypotension, increased hypotensive events, peri-op, and stroke. What about ACE inhibitors? Right. So clearly, when the patient has reduced ejection fraction, we do stop it. But the recommendation for stopping because of hypertension is not very clear, and I think there's still debate going on out there regarding that. Right. What about recommendation for diuretics and antiarrhythmic drugs?
Again, the diuretics also, it depends on the cause for starting it. If the surgery involves heavy fluid shift and heavy blood loss, diuretic should be stopped prior to surgery as it can cause hypovolemia and electrolyte imbalances.
This patient is on neither. Neither.
How would you like to investigate this patient?
I would like to do a complete blood count, hemoglobin to assess the baseline, to look for anemia since anemia decreases the myocardial oxygen supply, and also to calculate maximum allowable blood loss, total count to look for any active infection, platelet count. The platelet count will usually be normal even though the patient is on dual antiplatelet therapy, since the dual antiplatelet affect the quality of the platelet, which can be detected by bleeding time, thromboelastography, ROTEM. And I will do a random blood sugar, serum creatinine, and viral serology blood grouping. And I will also do an ECG to look for any old ECG changes or any new onset changes in the ECG, and also echocardiogram to look for the systolic function of the heart, ejection fraction, and valvular functions or any new onset region of motion abnormalities.
What is the validity of an ECG?
The validity of an ECG is, in this case, is 3 months if there is no new onset symptoms during that period.
What was the echo like in your patient?
Normal systolic function with grade 1 left ventricular diastolic dysfunction.
What is your idea about diastolic failure and its relevance in anesthesia?
Diastolic dysfunction is a condition in which the myocardium fails to relax completely, causing impaired left ventricular filling. So it can be in heart failure with preserved ejection fraction. And in this case, since the left ventricular is stiff, it is highly sensitive to rate, rhythm, and volume. If the patient is having tachycardia, it will decrease the duration of diastole and by decrease the left ventricular filling. And we should maintain the patient in normal sinus rhythm, because left ventricular filling depends upon the atrial contraction up to 40%. That atrial kick is important. And also we should care about the volume. Adequate fluid management should be done, because these are preload sensitive and the proper fluid is needed for proper contraction and filling of the left ventricle. And we should not overload the patient with fluid, as it can result in pulmonary congestion.
I know that both in your center and mine, we would routinely do an echocardiogram in a patient with history of CAD. But the newer recommendations don't really mention doing an echocardiogram for somebody undergoing a simple mastectomy. Would you know specifically in which patients I have to do an echo? I shouldn't miss the echo.
In patients having decreased functional capacity or patients having newer clinical signs within this 3 months, 3 months after taking an ECG or an echo.
So in the last 1 year, if there's a new sign,
clinical
symptom,
status.
very good answer. So if there's a new
Patient
symptom.
has something like that now, shortness of breath or increasing fatigue, would you like to investigate further?
Yes, patient is having a difficulty to do exercise stress testing or echo. We'll go for pharmacological stress test with dobutamine, adenosine, or isoproterenol, where there will be increase in contractility and increase in heart rate, just similar to stress testing.
Any role for coronary angiography? Maybe. If the echo, stress echo or the stress echo comes out with very bad scores, maybe
We can do a coronary
is one.
angiography.
What about CT angio? Can be done, but
What does it
high
tell you?
yeah.
Okay. Now the patient has come to you after stopping Cloplet for a week and having done all the investigations that you asked for. What are your instructions in the pre-op day?
On the day before surgery, I will take an informed written consent informing the risk and procedures involved, and also I will inform them about the NPO guidelines, 6 hours for solids and 2 hours for clear liquids, and I will inform which all medications that can be continued on the day of surgery, and I will give them tab pantoprazole 40 milligram, tab ondansetron 4 milligram, and for anxiolysis we can give tab alprazolam 0.25 milligram on the night and day of surgery.
So what is your plan of anesthesia?
My plan of anesthesia is to go for general anesthesia with endotracheal tube intubation and controlled ventilation. And to decrease the stress response, I'll give a erector spinae block.
Okay. So what other blocks can you give for this surgery?
We can give serratus anterior plain block, PEC 1, PEC 2, thoracic paravertebral block, intercostal nerve block, and even thoracic epidural.
Okay. So you've taken this case up for surgery. What are your main goals as far as anesthesia is concerned?
The main goal is to prevent the oxygen supply demand mismatch, and also to treat the perioperative ischemia. And also tachycardia and hypertension is also avoided as it can increase the oxygen demand, and even hypotension is also prevented as it can affect the coronary perfusion pressures, and nomothermia is ensured and fluid overload is prevented, and also perioperative ischemia is detected by continuous ECG monitoring.
Very good. You said supply demand. Can you briefly tell me what are the factors affecting supply and demand?
Factors that decrease oxygen supply are decreased coronary blood flow, decreased arterial oxygen content, and decreased oxygen extraction. Factors that increase oxygen demand are increased heart rate, increased wall stress, and increased contractility.
And factors affecting coronary blood flow?
The factors affecting coronary blood flow are decreased aortic pressure, or increased end diastolic volume, increased
Very
heart
good.
rate.
Very good.
Can you give us some insight into how you would monitor for ischemia?
For ischemia, we will connect a 5-lead ECG and we mainly monitor V5 and then lead 2. When there is a new or presumed new changes, dynamic or horizontal or ST depression of more than 0.5 millimeter in 2 continuous leads, or T inversions of more than 1 millimeter in 2 continuous leads with prominent R wave or R bias ratio more than 1, or transient ST elevation, we can suspect myocardial ischemia.
New arrhythmias also. Can you tell us the lead sensitivity?
Lead sensitivity, when we take lead V5, the sensitivity is around 75%. V5 plus lead 2, it is 80%. When we take V5, lead 2 and V4, it is as high as 96%.
Is there any role for a TE probe or IBP in a patient with ischemic heart disease?
In this case, it is less value, and in major surgeries, we can use transesophageal echocardiogram to look for any new regional wall motion abnormalities, because these will appear prior to the ECG changes on the monitor, so it is of much value. And invasive blood pressure is also of use, because beat-to-beat variability in blood pressure is important, because this can affect the myocardial oxygen supply and demand.
Okay, so now quickly walk us through the intraoperative management of this patient.
Once the patient is inside the, on the day of surgery, all the anesthesia workstation, multi-parameter monitors are checked and properly checked and kept ready, and ultrasound and and instruments for ESP block is also kept ready, and suction and difficult airway cart is also made ready. And once patient is inside the OT, patient identity is confirmed by name, age, hospital ID, and surgical procedure. Surgical safety checklist like allergies, and blood is arranged, and NPO status is confirmed. Once after the patient is inside the OT, we'll connect the ASA monitors, ASA standard monitors, that is NIBP on the left arm, NIBP on the left arm, and pulse oximeters, and the ECG lead is connected on the posterior part of the chest wall. A 20-gauge cannula is placed on the left arm, and ringer lactate is connected. And once the patient in sitting position, procedure of ESP block is explained to the patient. And procedure of ESP block is explained to the patient, and for anxiolysis 1 mg midazolam is given, and under strict aseptic precautions and under USG guidance, a right-sided ESP block is given with 20 milligram of 0.2% ropin and 4 mg dexamethasone. And patient, once after ESP block, patient in supine position, pre-oxygenation is done with 100% O2. Pre-oxygenation is done with 100% O2, and induction is started with injection fentanyl of 100 microgram and preservative-free lignocaine of 100 mg is given, and propofol and titrated doses up to 110 milligram is given. And after looking for the loss of verbal response and adequate chest rise and bag and mask ventilation, neuromuscular blocker injection, vecuronium is given for up to 7 mg is given. And after ensuring adequate chest rise and ventilating the patient for 4 minutes, a gentle smooth laryngoscopy of a duration less than 15 seconds is performed, and airway is secured with 7.5 mm cuff ET tube. After confirming the bilateral air entry and capnography, the tube is fixed at 20 centimeter, and post-induction monitors like temperature monitoring, peripheral nerve monitors, and capnography is also connected. Then intraoperatively, intraoperatively for pain management, injection paracetamol 1 gram is given along with tramadol, and fentanyl patch of 25 microgram per hour is also given. And for maintaining temperature, forced air warmers and fluid warmer is also connected. And intraoperative fluid management to replace the ongoing losses, prevent hypovolemia, and to prevent fluid overload is also ensured. And once at the end of the surgery,
What if there is tachycardia intraoperatively?
once there is tachycardia intraoperatively, I'll check for causes of tachycardia. I'll check for the blood pressure. If it is lower, I'll go for fluid management without fluid overload. I'll go for fluid management or vasopressors like phenylephrine.
Give a small bolus of
Bolus dose of fluid or vasopressors can be given. And if there is any hypertension, anesthesia plane will be deepened with volatile anesthetics, or boluses of propofol or fentanyl can be given. So once after the end of the surgery, the patient is given post-operative nausea vomiting prophylaxis like injection ondansetron 4 mg and dexamethasone of 8 mg is given. After ensuring spontaneous breath and trainer 4 value of more than 0.9, patient is reversed with neostigmine of 2.5 mg and glycopyrrolate of 0.4 mg, and patient is safely extubated and shifted to ICU for further management.
So dexamethasone can be given right at the beginning of the surgery, but ondansetron onset is about 30 minutes, so you would give it towards the end of the surgery. Peak duration is by 2 hours or so. Okay.
What is your major concern in this patient after the surgery?
Major concern is post-operative myocardial infarction. In patients with a history of ischemic heart disease or those who have severe symptoms or age more than 65, we would like to serially monitor troponin at 24 and 48 hours. And if the troponin is elevated more than 99th percentile, we would like to do a 12-lead ECG. And if the ECG is showing ST segment elevation, we will consider it as STEMI and do a coronary angiography and proceed it further. And if it is not ST segment elevation, then we will look for universal features of myocardial infarction like new symptoms of myocardial infarction or new onset ECG changes or pathological Q waves or any new regional wall motion abnormalities or any positive findings on the coronary angiography. If it is present, we will take it as ST segment elevated MI, and then we will look for plaque rupture. If present, we will take it as type 1 NSTEMI, and if it is not, then we will take it as type 2 NSTEMI. And if the features of myocardial infarction is absent, then we will consider it as post-operative myocardial injury and look for non-ischemic causes. If non-ischemic causes are present, then we will treat it accordingly, and then otherwise we will consider it as MINS.
What is MINS?
MINS is myocardial infarction that occurs myocardial injury that occurs during or within 30 days post-operatively, and it can be symptomatic or asymptomatic, and it is detected by evaluation of cardiac troponins.
MINS is not symptomatic. So MINS is non-symptomatic injury, right? No ECG changes, no symptoms. Yeah, go on.
And the patients of increased risk of MINS are age more than 65, and patients with known case of cardiovascular disease, or patients with age more than 45 years who have a risk of cardiovascular diseases.
Very good. So what are the precautions you're going to apply in the post-operative period? Is that also important for us?
Yes, patient should be further managed in surgical ICU, where all the standard ASA monitors are connected. Oxygenation is maintained above, SpO2 is maintained above 95 with simple face mask, and adequate normothermia is maintained, and patient blood pressure. Hemodynamic stability is also checked for, where mean arterial pressure should be more than 75 millimeters of mercury, and blood pulse rate should be between 60 to 70 beats per minute, and adequate analgesia is also ensured. with injection paracetamol, TID is given, and injection tramadol can be given. Fentanyl patches continued for 5 days, along with post-operative nausea vomiting prophylaxis like injection ondansetron 4 mg and pantoprazole is also given, and DVT prophylaxis like DVT stockings is also given, and patient is encouraged to go do for active mobilization of the patient is also encouraged.
What is the transfusion trigger for this patient?
As per the 2024 ACC-AHA guideline and MIN trial, liberal transfusion therapy, that is keeping the hemoglobin around 10, is more beneficial than restricted transfusion therapy.
What about you stopped an antiplatelet before the surgery? When would you restart that if you stop Clopilec? Because this is a low risk for bleeding surgery, you can start it by 24 hours, right? I think you can pat yourselves on the back. You did a very good job, both of you. Thank you so much.
Thank you, ma'am.
So just to complete, we said about echocardiogram when we should do. So that is, like our student mentioned, if there is new onset of symptoms or unstable, the patient is unstable when you're assessing, or if there's a new murmur. If you can hear a new murmur, you would definitely ask for an echocardiogram. And also, because this patient is for a CA breast, if she has received neoadjuvant chemo, there is some risk of cardiac failure that's going to increase. So ask for an echo. Thank you.
Thank you. I would like to thank both Aarati and Ajanya, who actually did all this presentation within a very short time, and Ashu ma'am for taking time out from OT to guide us through.